good afternoon from Malaysia. I think this is the time we should start. This is our 11th monthly webinar. And for this webinar, we have nearly 400 members who have registered for this webinar. Unfortunately, I have to start with a sad news today. Our colleague and active member, Dr. Fazal Ghani, who was the principal dean of Peshawar Dental School, passed away last week. Our condolences to the family and prayers for him. May Allah grant him highest place in Jannah. Right now,
Amen. Amen.
What we are facing now is starting with the statement of a problem. And the problem is that what medical schools claim about the capabilities or competencies of the graduates and what is the real situation. And we know this is a well-known problem, that there are gaps in what entering residents or house officers can do and what they have been documented or claimed as competent to do without supervision. So there is always a complaint from especially from the clinicians when the new house officers join, that they do not possess the required skills. And competency-based medical education strives to resolve this issue. So that's the background with the complaint of the clinician, most of the time the clinicians, that the house officers entering into the training do not possess the required competencies. So about 8 years ago, in 2013, American Medical Association announced a program to offer 5-year grants to 8 to 10 medical schools. And the goal was to create innovations for the medical schools of the future, and specifically to narrow the gap between the claimed and the real competencies of the entering house officers or entering residents. For this, more than 80% medical schools in the United States, they applied. 30 were invited to submit the detailed proposals, and 11 medical schools were awarded a grant of $1 million each. So this was 8 years ago, and this project was for 5 years. The goals specified were that the medical schools who have been given this grant should devise a curriculum which caters for the competency-based assessment and flexible individualized learning plans, exemplary methods to achieve patient safety, performance improvement, and patient-centered team care, and understanding of healthcare system and healthcare financing or healthcare delivery system. This is what they call is the third pillar. The first pillar being the basic medical sciences, and second pillar being the clinical sciences. So they recommended that there should be another component apart from those two, is that the medical students should be taught about the healthcare delivery system in whatever country they are. And of course, optimizing the learning environment. So these were the goals given for to 11 medical schools, and who were given a $1 million grant for 5 years to work on that. And this is the outcome of that research and a grant. The medical schools of the future, they will produce the lifelong learners and the physicians who can deal with the diverse population of the patients, both underprivileged and the other patients. They would be able to use the advanced technology not only in teaching, but also in diagnosing and management of patients. Team-based care, so working with the other, they must have the ability to work in the team with other professionals. Competency-based education, and they should be familiar with the healthcare delivery system, and they should be focusing on the patient outcome. So that was the outcome of that research and the outline of a future medical school. These are some of the medical schools who have already adopted this system, and some we can see some very famous medical schools like Harvard, Mayo Clinic, Brown, and others who are practicing this competency-based medical education in the United States. So with that background, our plan, our outcome is that the participants of this webinar will be able to discuss the rationale of competency-based medical education approach, explain the concept of entrustable professional activities in CBME or EPAs, explain methods of assessment in competency-based medical education, discuss different approaches for implementation of CBME, and discuss the advantages and disadvantages of CBME. Apart from this, we would be answering a question as well. And the question is that since medical students do not necessarily learn in the same way or at the same pace, why should they all be taught in the same way and the same pace? And can medical students be taught in ways compatible with their learning styles and the pace? And this is another aspect which competency-based medical education addresses. Now, while trying to understand the concept of the competency-based medical education, it's important that first we understand what is professional competence. Here is a very comprehensive definition: the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and community being served. I think the important word here is habitual and judicious, means that it should become a habit of a physician to use all these attributes to serve their patients, and that is one definition of professional competence. Competency is an observable ability of a health professional, integrating multiple components such as knowledge, skills, values, and attitudes. So that's what the previous definition also mentions. The additional point here is that since the competencies are observable, so they can be measured and assessed to ensure their acquisition. So competencies must be observable and must be measurable. Now, coming to competency-based medical education, and this is the most important part to understand competency-based medical education, as it combines an intentional and transparent approach to curricular design with an academic model in which the time it takes to demonstrate competencies varies and the expectations about learning are held constant. So this is totally in contrast to other curricula where time is fixed. But here in competency-based medical education, time is not fixed. It is the attainment of the competencies which is important. So this means that if a student can attain those competencies, let's say before than 5 years, or they may take more than 7 years, so it doesn't matter how long time they take. So time is variable, but the competencies are fixed. So it is not a time-based program. That is one major difference from the other curricula. The other point, students acquire and demonstrate their knowledge and skills by engaging in learning exercises, activities, and experiences that align with clearly defined programmatic outcomes. So this is another big point, that outcomes are clearly defined and rest of all the activities, learning activities and assessment activities must be aligned with those outcomes. So it is in a way a top-down approach that first we identify the outcomes, then rest of the things follow them. And the third point is that the learners earn credential demonstrating mastery through multiple assessments. So important thing is that they have to demonstrate the mastery before they can be uh, uh, allowed to graduate, and many times it can be on personalized basis. Now, comparing the discipline-based and competency-based curricula, we move from objectives to outcomes, from contents to the competencies, from norm reference to criterion reference, teacher-centered to student-centered, passive learning to active learning, summative evaluation to formative evaluation. That is a big difference as well, because in competency-based medical education, the assessment is a continuous process and mainly on formative basis. Instructional delivery to learner performance, knowledge focused to performance focused, assessed by counting, where the numericals numbers are used, whereas in competency-based medical education, they are assessed by level of performance. So the supervisors deciding about whether student has achieved that performance. And then, as I mentioned earlier, that in discipline-based, there is a pre-assigned time, whereas in competency-based medical education, time is decided by the outcome of the assessment. As far as the first point is concerned, objectives and outcomes, we had one full webinar on that, objectives to outcomes, to explain the difference. The competencies which are part of, are the most important component of competency-based medical education. They are derived from analysis of societal and patient needs. So this means that these competencies required might be different in different settings or in different countries, depending upon the needs and requirement of that nation. The second point is that it de-emphasizes time-based training and promises greater accountability, flexibility, and learner-centeredness. Accountability in the sense that medical school has to be responsible that whatever they claim that the student has these competencies, they are accountable, as well as student is accountable. Flexibility in terms of learning, because it's not time-based, and of course it is learner-centeredness. If we want to understand the structure of competency-based medical education, it can be understood by considering these 5 pillars. First is entrustable professional activity. This is an interesting concept, and I will be explaining about it in a short while. Then the competencies, milestones, assessment system are programmatic assessment, and then the personalized guidance. So we will talk about these points one by one. EPAs are set of activities or units of work that entering residents should be expected to perform on day 1 of their residency without direct supervision. Means these are the units of work or activities which student has done it completely and has been certified to be competent in that, and they are able to do these activities on the first day of their housemanship independently without their supervision. So the medical school has certified that this graduate is capable of doing this activity, for example, a procedure, without any supervision. So that is one definition of EPA. So important is that it is an activity or a unit of work. Activity, for example, can be a history taking in a patient of myocardial infarction. Unit of work may be a lumbar puncture or maybe collecting arterial blood sample. So these are the capabilities which medical school has to certify that a graduating student will be able to do on the very first day of joining as house officer and will be able to do independently. Of course, the EPAs include knowledge, skills, attitude, and problem solving skills. So to handle any activity or any unit of work, they would require the background knowledge and skills and attitude to handle that. And these EPAs are used to make decisions about the level of supervision or the progression of the students during their undergraduate time. Means that the same EPAs are used to assess the students, because the medical school has to make sure that students have achieved those EPAs before they graduate. Then for each EPA, there is a set of competency. We will explain in a short while, but just to achieve, for example, taking history, there has to be number of competencies required before student is able to take the history or perform any procedure. In 1999, the CBME and ABMS, they divided these competencies into 6 domains. Actually, all the medical schools, they came up with different sets of competencies, and then they were combined and they were grouped into these 6 domains. First, patient care and procedural skill. So competencies in relation to performing procedures and the patient care. Then the medical knowledge. Practice-based learning and improvement means the ability as a lifelong learner. Interpersonal and communication skills, professionalism, and system-based practice. System-based practice is related to the one I was explaining, like the third pillar are the health delivery system. So whatever competencies we think the graduating medical student should have, or entering house officer should have, they all can be grouped in these 6 domains. Level of competencies and milestones. So each competency has many levels of competence or milestones to achieve before competent. Of course, when the medical school, a student enters the medical school, he is at the very beginning state, a novice, and then by the time of graduation, they have attained certain competencies, and in between there are number of levels. So each competency has number of levels from the very beginner to the expert, and those levels can be used as a milestone, and student has to achieve all those milestones before they become competent. Milestones are performance levels. As I just mentioned, it is not time, it is the level of performance which makes a milestone, and that describes the developmental stages of medical school along a continuum, from a novice learner to to a proficient learner over the period of time in medical school. So these are the milestones, and again, they would help to decide whether student can progress from one stage to another stage. Competency levels, the different organizations have defined it. For example, American Association of Medical Colleges, they said there are 2 levels of competence in undergraduate medical students, one at the time they join and one at the time they leave after graduation, and of course in between there are a number of stages. Whereas in graduate medical education, there are 5 competencies levels, from novice to advanced beginner, competent individual, proficient individual, or expert physician. If we extrapolate this to the undergraduate, so the beginning is novice, but the graduating may be at any level, maybe advanced beginner or competent individual or proficient individual. So this is what the institution has to decide, that at what level should be the competency at the time of graduation of a medical student. We can also use Bloom's taxonomy to assess the level of competence. And similarly, the Miller's pyramid can be used for this purpose. However, when it comes at the DOES level, there would be a levels, the multiple levels, that means the different levels of competency. So in summary, EPAs are final outcomes, a broad statement, for example, history taking in a patient with myocardial infarction. Many competencies are needed for execution of an EPA. For example, if we take the example of myocardial infarction, of course, there would be a number of competencies needed to take that history and perform the physical examination. Each competency has many levels or milestones to achieve before becoming competent. Milestones are separated by training stages. Of course, from one milestone and moving to the next milestone, there has to be some training. And the competencies and their milestones become the building blocks for the EPAs. So this is the summary so far, what we have discussed in relation to the concept of competency-based medical education, and the terms we use, what is meant by EPA and what is meant by milestone and the competencies. This is a demonstration of the same concept, that the EPA are entrustable professional activity, and then one of the 6 domains which I mentioned. Then each domain would have multiple competencies, and each competency, like we said, for undergraduate student, we divided into 2, the novice or the entry level and at the graduate level. So it may be milestone 1 and milestone 2. So this diagram explains the same concept. As compared to the milestones, the pre-entrustable learner are the entry level is the beginner, and this would be when the student is graduating. So we can divide those into multiple milestones. These entrustable professional activities would be different, obviously, at a different level. The EPAs for a graduate medical school, and then would be means those for entering in a residency, then EPAs for a postgraduate student, and EPAs for specialists. Of course, they would all be at different levels. But point is that this concept can be applied both in undergraduate and postgraduate training. Here is an example to explain that. The EPA is a common diagnostic procedure, means that uh, entering resident or entering house officer would be able to perform common diagnostic procedures, and then we would have a list of what we mean by common diagnostic procedures. And then so if we say common diagnostic procedures, they would come under the domain of patient care and procedural skills. And the competency, for example, we are talking about a procedural skill of arterial blood sample. So to achieve that competency, we would have number of milestones. For example, knowledge of anatomy of location the artery maybe in year 1 and year 2. Then coming to skills, aseptic technique, maybe year 3. The attitude, taking consent and communication, maybe level 3, year 3 and year 4. And then when we come to the actual procedure, we have different milestones or different stages. At first point, the student would observe only, that is the entering level or novice level. Then they practice with direct supervision, then practice with indirect supervision, and then perform without supervision, and finally are able to supervise others. So these all can be the milestones. So once, let's say, the student has been seen by doing those procedures under supervision, and the supervisor is happy with that, our group of supervisors are happy with that, so they can allow the student to practice in indirect supervision. Means that student can perform that procedure, but the consultants are around nearby, so if needed, they can be called. And then finally, if they are happy with this stage, then student can move on to the next level or next milestone, which is performed without supervision. So this, I hope this example can explain the concept of EPA and domains and the competency and the milestones. This is another example where the Accreditation Council of Graduate Medical Education, they have drawn this. And if, for example, we see the last one, which is chronic disease management, of course, for that, there is a medical knowledge, there is a patient care, there is the interpersonal skills and communication, the professionalism. So for each EPA, the competencies can be identified and put in a table, and then each of these competency level can be a milestone for students' progression. Now, coming to the next concept, which is entrustment, and again, it is a very, very important component of competency-based medical education and EPA entrustment, and it is very different entity from competence. It is the trustworthiness. Entrustment is defined as trustworthiness in applying knowledge. A person may be competent, but may not be trustworthiness. So that is a big difference in assessment. The whole angle of assessment changes when we come to this concept of EPA. The only competence is not enough to be trustworthy. To be trustworthy, student must consistently demonstrate attributes such as consciousness, knowledge of their own limits. So they should not be able to recognize the situation where they need help-seeking behavior, truthfulness, and they must have all these attributes to win the trust of the assessor, and only then the process of entrustment would come into play. Throughout the course, the students should be assessed on trustworthiness. though this may occur implicitly or explicitly, but EPAs make it more transparent and explicit. Clearly, the assessment of ability is not sufficient to arrive at a trust. Trusting a trainee to do something critical in patient care requires consideration of risks and benefits. Entrustment-focused assessment is critically different from assessing performance. It requires thinking ahead to what might happen in the near future. So we can all feel that to trust somebody is much different than simply achieving a competence. And this decision is usually made by a group of supervisors and they decide whether student has achieved that level of entrustment or not, and if has achieved that level of entrustment, whether they can be certified for that. And of course, there has to be an evidence. It has been recommended that there should be a committee and who should look at the evidence available before they make a decision of entrustment about a certain professional activity to allow the students to perform. So in summary, the attributes required for entrustment is capability. Number one, there should be specific knowledge, skills, experience, situational awareness. Integrity is very important, truthfulness, patient-centered, benevolent. Reliability, consciousness, predictable, accountable, responsible. Humility, recognizes the limits, and does not try to be hero. As soon as feel that there is some limit, recognizes and asks for help, and is proactive in work and in team. So we see here that capability is just one attribute. There are a number of other attributes which are not related to capability, to knowledge or skills. It's the integrity, it's the reliability, it's the humility, it's the agency. And that makes it very clear that the approach in competency-based medical education is very, very different than the other curricula. If we look at the EPAs, they may appear exactly the same what we have in other curricula. But when we look at the implementation, and especially the entrustment part, and especially the assessment part, it becomes very, very different than our current approach of doing the things. Right, so that is so far what is competency-based education and what is entrustment. And now next is how to implement this competency-based medical education. On paper, it seems an excellent idea, but whether we are able to implement it, practice it or not is another aspect. Teaching learning methods are more or less same as we are doing in other curricula, the student-centered, the self-directed learning, directed self-learning, team-based learning, interdisciplinary seminars or interactive lectures, flipped classrooms. So teaching learning methods are not different. The major difference comes in assessment. There has to be clearly defined competencies and EPAs, clearly defined criteria for progression. So means for each EPA, there should be set of competencies, and for each competencies, there has to be levels of competencies or milestones, and student progress depends upon achieving those milestones. It is mainly a task-based rather than time-based approach. So the targets have to be challenging. And of course, the methods of assessment must be valid and reliable. Objective continuous assessment, that is the major focus is the continuous assessment and a personalized assessment. Each student would have a personal record of assessment and being monitored by somebody. And other thing is the interpretation has to be consistent among different examiners. If the consistency is not there, that can seriously endanger the whole system. Competencies have to be assessed throughout the student learning continuum, means that it is a continuous process rather than having periodic assessments. This is a kind of continuous process. I mean, the student is being monitored by somebody, and maybe they are writing a report or comments on daily or weekly basis. Reliability of assessment of these competencies can be improved by increased frequency of assessment, means that if we want to implement this system, there has to be a number of assessments, but of course not in the way that we assess. Presently, there would be different ways of assessment, and that assessment is built into the daily work done by the learner and teachers. So it's not a special separate exam, but it is the continuous monitoring of the students by their supervisors. CBME focuses on individual needs and development. Basically, by continuous monitoring of students, the supervisor can identify the gaps or the deficiencies in the student and can guide the student accordingly and help the student to strategize to address those deficiencies. So it clearly identifies the individual's educational needs and guides them. So this means that there may be individualized guidance for students based on their level and performance. In fact, in this, there is no pass or fail concept. It is whether moving from one stage to another. So different students might be moving at a different pace. So summarizing the assessment, there has to be milestones at multiple occasions, multiple levels of milestones. Competency-based, which includes knowledge, skills, attitude, problem-solving skills, values, rather than time-based. Continuous assessment, for example, monitoring of skills, whether the student is learning those procedural skills and there is a continuous monitoring and gradual improvement in the skills of the student. Work-based assessment, for example, looking at the attitude, and individualized feedback on assessment. So every student would be given a feedback based on the assessment by the supervisor. The methods and tools of assessment are mostly the same which we used previously. It can be in form of OSCEs or objective assessment of technical skills or procedures. Mini-CX is most commonly used. Simulation experiences, role plays, standardized patient examinations, computer-based virtual cases, and the logbooks in the documentation. So these are different methods, but more than that is the 360-degree evaluations, means that the feedback from different people who come in contact with the student. If it's a clinical student, the checklists are patient surveys, are sport staff observation, faculty observation. So this would be a different approach than what we do under present systems. Direct observation in clinical settings, again, continuous monitoring of the student, and then reflective writing and portfolios, and then, of course, the written examination. So the customized curriculum, so as I said, that the individual student is given individual guidance, so it's become sort of customized curriculum for each student to work on. So there would be, of course, additional roles of the faculty. The faculty members closely monitor students' academic progress. It's a big job and big responsibility. Help students set personal goals and strategize. Determine students' readiness for advancement through the curriculum based on the demonstrated competencies. So this means that every student would have a mentor or a supervisor. So maybe each lecturer might be supervising a number of students and guiding them along the way. So that it would be the role of faculty in this situation. Of course, if we do that, there would be students who are fast learners and there would be students who are slow learners. And as I said in the very beginning, the basic difference in CBME is the duration is not fixed. It is the capabilities which are important to achieve. So there might be a situation that some students are able to graduate before 5 years, and there might be a situations where students take longer time. There are suggestions that if we want to still fix the 5 years, so we can have some additional modules or additional training for those students who are in rapid progression, so that they can graduate not only with the medical degree or maybe an additional degree. This is another idea which I have floated previously also in a number of opportunities. That if we are following the competency-based medical education, so there could be some specialties which can be trained independently. Right, the one example is the BDS, the dental surgeons. They are trained on dental surgery. They don't have to learn rest of the medicine. They just focus on that. And probably that can be done in case of ophthalmology and otorhinolaryngology, that whether we need to think, is it necessary for a student who is very clear from the very beginning that he want to be an ophthalmologist or he want to be an ORL surgeon? Do they really need to go through a 5-year MBBS program before they go for ophthalmology or ORL? Or can they be trained like in BDS? So a curriculum can be designed and where they can cover the manifestation of systemic diseases in eye or ENT, and then we can have the ophthalmologist or ENT surgeons on a fast track without going through first 5 years of MBBS and then going through these courses. So this is an idea we can think about it. Now, having said all that about the competency-based medical education, not everything is rosy. There are other aspects of it. Reaching specific level of competency would need to be assessed through frequent performance evaluations. So means there that might end up with having a number of assessment although it can be embedded into daily work, but that can produce cause an extra burden both for the student and the staff. Then the costs of administration might be quite high, because you would a supervisor would be able to handle only a number of students, and if we are having so many students, so there could be problem in that situation. There would be fear that we are spending more time on admin than rather than on quality improvement. With individual medical programs seeking to serve their population best, so the competencies might be different in different institutions or in different countries, depending upon their requirement of their society and the patients. Issues relating to starting residencies at different times means that the fast graduating students will be able to start a residency earlier, whereas slow graduating students would take longer time before they start the residency. So there would be different times of starting the house job or the residencies. We might focus only on competencies, and we might forget the process, but process is as important as competencies. So we cannot afford ignoring that. Sometimes if we become too meticulous and we start breaking down competencies in minute components, and then that can end up with endless lists and goals, and that might be frustrating. If the focus is only on milestones, the learners might perceive that that's only their target, that they have to achieve only these milestones, and they may not be striving for excellence in that particular area. Now here I'm going through some core EPAs which have been identified by American Association of Medical Colleges, the 13. And when you go through that, you wouldn't find it very different than existing what you call is the outcome or objectives, but we would see that and we have seen that the achievement and the criteria to achieve those EPAs are very different. Gather history, perform physical examination, same as we have under present circumstances. Prioritize differential diagnosis. Again, it's not different than our present setup. Recommend and interpret common diagnostic and screening tests, same as we have now. Enter and discuss orders, prescriptions, same. Now, document a clinical encounter in patient record is same. Provide an oral presentation of a clinical encounter, same. As I said, they do not appear different than what we are doing presently, but when we go into the detail and to certify whether they are able to do this or not is a totally different process. Give or receive patient handover to transition care team. Collaborate as a member of interprofessional team. Recognize a patient requiring urgent or emergent care, and so is the consent and the procedure. So what we see here is, although this seems to be same as we are doing now, but the process of entrustment is different. And second, the CBME makes sure that whatever is written here in these 3 EPAs is really implemented, and a graduate student is definitely able to do that, which may not be the situation under present circumstances. Here are some further examples to explain the EPAs. I have been requested by some of the members to explain more about the EPS and the concept. So here is the let's say we have one EPA is obtain a complete and accurate uh, history in an organized fashion, and then we see that there are a number of levels. The novice is that does not collect accurate historical data, relies exclusively on secondary. Then it moves gradually to more mature state till it obtains a complete and accurate history in an organized fashion and seeks secondary resources information. So we can see that the in between there would be the milestones and student would be. So we can have whether student moves from this, comes to this stage, and then comes to this stage and this. So a supervisor can monitor the students and the progress, and they can certify that student has achieved, and by the time they graduate, they have achieved this level. Similarly, in terms of interviewing or going into the physical examination and the patient care, so we can see all these milestones and the supervisor role in allowing the students to move to the next stage. And this is about the steps in physical examination that at beginning, for example, student doesn't consider the patient's privacy, and then slowly they learn about it, and at the end they perform an accurate examination in a logical and fluid sequence and uses the exam to explore and prioritize the differential diagnosis. So this now again you would say that this is not different than what is happening, but at this what although the student is going through all these stages, but under present circumstances, there is no monitoring of students, and there is no really one-to-one guidance to the students how to improve that. So that makes it different in competency-based medical education. This is a link in New England Journal of Medicine. They have given a series of these articles written in very simple and easy readable manner, and if you like, you can go through that, and I found it very useful. I'm sure you'll find it useful as well. With that, I thank you for your attention. Just to say here that in FCPS in Pakistan, there is a and MCPS, there is a recognition of competency-based model, but I'm not sure how much or to what extent it's being implemented. Thank you very much, everybody. If you have any questions, I would be happy to answer that.
Assalamu alaikum, sir. I am Dr. Danish. May I ask a question, please?
Yes, please.
Sir, I have seen the EPAs as designed by AAMC into 13 different types of EPAs, and each EPA consists actually of a small segment of actual professional activity like patient care. For example, if a student encounters or a resident encounters a patient with an acute illness, he has to uh, practice and perform and demonstrate all those competencies in an integrated manner, including history, examination, physical examination, the investigation, planning, decision of drugs, etc., etc.
That's
Why
right.
shouldn't we design EPAs in such a manner that after completion of a particular EPA, the student should be able to take care of a whole patient with an acute illness or a chronic illness or a communicable disease, etc., etc. It would obviously include all those EPAs as defined by AAMC individually, but he will use them in an integrated, comprehensive manner, and probably will be able to more easily translate it into professional practice. Thank you.
Right. No, Dr. Ganesh, I understand that. And if you see, I gave an statement in that this is a broad statement. Basically, when we say that students should be able to do, for example, common procedures, then we have to identify what do we mean by common procedures in our own setup. So means that each EPA, although I'm giving a statement, you have to come under that EPA a detailed description. For example, we say the patient should be able to take history. So EPA cannot say it should be able to take history in myocardial infarction, in acute gastroenteritis. In EPA would say only that they are able to take history in common illnesses. Then it is our job to identify what do we mean by common in our own setup. So these EPAs, you are absolutely right, very broad guidelines. So once a medical school has identified common illnesses they are talking about, then they have to make sure that the students have gone through one by one. And you're right, as you said, they are focused, they are minute because of the for assessment purpose. If they are not focused, they are not minute, then the assessment may not be able to be conducted adequately. So remember, when we say an EPA means that we have to expand that EPA under our own situation. I hope that answers the question.
Thank you, sir. Thank you very much.
I'm Dr. Anila. Can I ask a question?
Sure.
One question, please. One is what I think is that in order to design this competency-based curriculum, first of all, we need to identify our common diseases in Pakistan, list of common problems which we need to make them practice. And if what I see is the limitation in that would be that if someone is trained in competency-based curriculum in Pakistan, would not be proficient in the developed countries. Maybe they supposingly if they don't have malaria, they don't have tuberculosis, and we do train our students in that, and when they go abroad, they would encounter different diseases which we may not have trained them. First thing. Second thing is that this is the I think is the same model which the initially apprenticeship the mentor system, which was apprenticeship was in the initial 1960s, which was done one-to-one student and supervisor training. That is basically the concept of this CBME.
All right. Thank you very much. Let's talk about the first situation. You are absolutely right. You see, let's say you train students in your own country, and at that time your focus is to train workforce for your own country. Now, whenever students want to go abroad or somewhere else, they have to appear in their exams and they have to prepare for that. Similarly, for example, a student graduating from UK want to come and practice, for example, in Malaysia, they might have never seen a dengue fever. Here it's so common. They may not have seen even malaria. So every graduate, when they want to go to some other country, they have to learn about that. So I think none of the country, they prepare their students to serve in other countries. Every student is trained to serve in their own country, but when they want to go abroad, they have to, like, for example, if you want to go to UK or US or Australia, obviously you have to appear in their exam, and for that you have to prepare for their exam. So, and even if we follow what you are saying, we may not be able to train a student to work in all the countries in the world. So I think that is the point which comes after graduation, and depending upon the country wherever that student need to go, so they have to work for that. The second point, you said 1-to-1. Yes, it is one component of this competency-based medical education. The mentoring and the supervisor role is very, very important. And that's why I was saying that it might create the extra workload for the staff. Now, I have just seen somebody mention talking about the regulatory bodies. For example, if it is a regulatory body says that you have to minimum of 5 years, then of course we have to do minimum of 5 years. The one thing is that when I'm presenting this, I'm just sharing the ideas. So you can look at the benefits and you can look at the drawbacks, and then you can see whether it is you can implement or not, or whether you can convince your regulatory authorities to follow. As I shown you the example that number of medical schools are following this, I was actually surprised when I read that in Canada, even there are some schools, of course, they are taking postgraduate students that they can graduate even in 3 years. So obviously, if we want to implement this, we need to convince our regulatory authorities. Second is, as I mentioned, second suggestion is that for these fast learners, we can have some additional opportunities, additional courses, or certificate courses, just within the period of that 5 years.
Assalamu alaikum, sir. Can I ask a question, sir? This is
Yes,
Aisha Abdullah.
Yes.
So two things. One is an affirmation that I want you to confirm that the way I have perceived EPAs, is it correct understanding or not? In the Miller's pyramid, I see the entrustment at the top of the Miller's pyramid. And
Right.
that's how this entrustment and the EPAs, the authenticity of EPAs in our medical practice stands, as far as I could understand it.
Right.
Secondly, sir, in our medical college, we have incorporated this concept in the monitoring of our house officers. And we have created an electronic system in which they have got, they get these different tasks signed off by the consultants. The problem that we are facing in that is, and which I think would get across all the spectrum of EPAs, but at the undergraduate and postgraduate level, is that a lot of supervision is needed by the consultants. And by the end of the day, there's a lot of documentation that has to be done. Since it is embedded in the working environment and the daily work, almost daily the consultants and the trainees have to enter a lot of variables in the system. So it's an additional cognitive load on the trainees and the consultants, at least in the beginning, since our system is just 2 years old. So what do you recommend to, how do you recommend to manage that?
Dr. Aisha, you are absolutely right. Absolutely right. There's the problem in implementation. And when you are saying that you are doing in house officers, I think that is the best opportunity to implement CBME and learn from that. Of course, the workload is increased. As I mentioned, you and you also said that the house officer and the supervisor might have to meet every day. Let's say by the end of the day, they have to meet briefly, and the supervisor might say that what mistake was done or what deficiency was there and how to improve on that. There's no doubt in that. But from my point of view, if we want to implement CBME, probably house job is the first stage where we should start doing that, and then it can trickle down to undergraduate students and then also to postgraduate students. But there is no doubt that the supervisors and the students, they have to take extra responsibility and work on that. but I'm sure that that would pay uh, in terms of good training. Second, the first one you said about the Miller pyramid, yes, it is at DUS level, but we know that at DUS level there could be different levels as well. So it is a competency and there are milestones. So students might be doing things at different levels. So DUS would be the top part of Miller pyramid would be further divided into multiple levels of competencies.
Sir, what I meant was that it is at the top of the even does. If
Right.
somebody does, but not necessarily could be entrusted with certain tasks. So in the Miller pyramid, we are seeing another category coming up, which is above the does.
That's right. And that's the difference between competency and entrustment, or competency and the trust. So does is up to the competency and trust comes on top of that. So whether supervisor has our student has been able to get the confidence and the trust of the supervisor, that would be above the does level. Right? Any other questions? Dr. Ishtiaq?
Assalamualaikum. Can you hear me, Dr. Nikat?
Yes, please. Yeah.
Okay, sorry, I lost sound in the last 7 minutes. Firstly, I would like to ask you that when you are saying that it is a level, trust is level above does that mean that each EPA that we are entrusting them is to the level of mastery of that graduate? Number one. Number two, if we are going to implement CBME, like you might have heard that we have now Pakistan Medical Commission in Pakistan and they are revamping the curriculum.
Right.
What would be the specific and general faculty requirements for implementing the CBME?
Right. Okay. Now the first question.
Thank you.
The what you said is mastery. It depends what the medical schools are in. In other words, let's say at the national level, the Pakistan Medical Council decides. So whether, because we mentioned that there are milestones. It can be just a beginner, or then it can be an advanced beginner, or it can be the competent, or it can be expert. So there are a number of levels. So in some areas you might expect mastery, and whereas in other areas you may expect something less than mastery. So it is the policy decision which has to be done by the medical school and the Pakistan Medical Council in that particular situation which you are mentioning. Second, the faculty, the first thing which we need to do is faculty development. In faculty development is how to assess and how to monitor the student, or role as a supervisor, because that is the major part of competency-based medical education, which separates it from other curricula. So apart from whatever I have mentioned, the most important would be the methods to assess and consistency in assessment, and the similar understanding among the supervisors, so that when they assess, there is no big difference in different assessments. So definitely we would need the faculty development, and the faculty has to be ready for some extra work to do when we are implementing this competency-based medical education.
Sir, can I just add a comment to this? What I think that this dilemma that we are facing with competency-based education is the increased workload of the faculty can be reduced by the use of technology. And especially during this COVID period, we have seen that technology can come to our rescue a lot.
Yeah, I think that's a good idea. Definitely the technology can help to some extent, but the observation of, let's say, when you were talking about the house officers, the supervision is very important component. Yes. Are there any other questions? Is Dr. Ishtiaq around? Wanted to ask some question? Right.
Assalamu alaikum, sir. Can I ask a question, please?
Yeah, sure, please.
In this CBME system, should be there any ideal teacher-student ratio?
Yeah, I don't think there is any ideal student-staff ratio, but as we were saying, that the increased workload, and if the staff has to monitor the students, so maybe that's a one, probably just guessing that one supervisor can monitor or supervise, let's say, around 10 students. So so that kind, if you want to really calculate the ratio, and but it is much easier done in the clinical years when students are divided into small groups and they go into the rotations. So that can be done much easily in clinical years as compared to preclinical years. And as Dr. Aisha was saying, that doing it during house job, then of course it's it's a kind of must requirement that the house officer need to be monitored and supervised for all the activities.
Thank you, sir.
And thank you very much, everybody, for your attention. Just a couple of slides I want to share. As usual, about the coming webinar, which would be on 21st of February, and that is on student mentoring and tracking system. So we have been talking a lot about student monitoring and mentoring during CBME, so there would be further discussion on that, and also on the tracking system. This webinar would be conducted by Dr. Rukhsana Hussain Malik on 21st of February, about the same time. And the next is my usual request that each participant, may I propose to each participant to donate $1 USD or equivalent amount in your local currency to any deserving individual in your neighborhood or any public welfare organization in your community. And if you have any other questions, you can always WhatsApp me those questions, and I will try to answer as much as I could. And I thank you for your support and for your patience and sparing time to attend this session. Thank you very much.